Welcome back to Coffee Talk with Mike and Janell. We are on episode 15. Today we're going to extend the conversation from last week when we were talking about depression, and we're going to delve into catatonia. What is catatonia? It is a very marked and distinctive and obvious decline in movement and functioning for a lot of people. And in my brain, I kind of conceptualize it as a deep, dark depression. So, Michael, I do have a few stats I want to quickly present, but then I'm going to have you kind of talk a little bit more specifically what catatonia looks like. I know most individuals with autism, there's 12 to 18% of folks who are diagnosed with autism that will have catatonia, and it typically presents between like the age of 15, 20, on average about age 18. So I'm going to hand it over to you so you can talk a little bit more about specifics of what it looks like and maybe diagnosis and treatment.
Okay. Yeah, I mean, it's actually kind of striking, and to be honest, it was probably only a couple of years ago when the concept of catatonia really, in autism, in developmental disabilities, really kind of came to apex awareness and attention. So catatonia in general, what does it look like? There's a couple different kinds. There is catatonia that we call active catatonia, where people kind of have this purposeless movement where they're just moving and moving nonstop and is life threatening to the point that they move so much that they burn through all their energy stores and back associated with untreated major depression, untreated psychotic symptoms and psychotic disorders. Back before there was medications for treatment in the early 1900s, mid 1900s, really, life-threatening conditions. There's also a catatonia that is kind of the opposite, where you're not super active, but you almost become
like comatose.
Yeah, unmovable, to the point that you stop speaking, you stop caring for yourself. You're very rigid. There's actually even something where they talk about like this concept of waxy flexibility, where you can take someone's arm and move it up and move it yourself and then let go, and it'll stay there, almost like if their arm was made out of wax and you've moved it. And those are classically described in the psychiatric literature, particularly during the era before there was medications and other treatments. So there's no reason to not think that this can't also happen with people with autism. It's been described more frequently with individuals with Down syndrome, but more recently talking about people on the spectrum as well. But when you start talking about potential rates of 12 to 18% of people on the spectrum may have catatonia or catatonia-like symptoms. If you say 1 in 54 people, 2% of the population, 18% of those, it's far more prevalent than most prescribers, most psychiatrists, nurse practitioners, psychologists would believe. Far more prevalent than I would have considered before we started treating these cases on a regular basis and really doing literature reviews and whatnot. So it's obviously, it can be a big deal. And I think what makes it a bigger deal in the population that we treat, particularly Down syndrome and autism, is because if you're not looking for it, you won't find it. And what very often happens is, if you think about the ages that you mentioned, average age 18, 15 to 20, think about individuals with developmental disabilities who are in school. They have an IEP, an individualized education plan.
It's a big transition time.
Structure, support, all these things. And as they're aging out their educational programming, sometimes they move into a very robust adult program, but very rarely will that adult program replicate what the support and services they were getting during school.
For sure.
And what we've seen, the first case that we ever saw was a young lady who had finished school, who was functioning at a very high level, was very social, was able to get her driver's permit and all these other things. And when she came to us, she looked like she was cognitively, neurologically ill. And everyone looked at it as though it was a sudden change. But when you took the real history, when she left school, she lost social connections. Those were losses. Those are very big traumas to our population.
Yes.
Loss of support, loss of pleasure in her life.
These were incremental losses over time. It was just not marked and distinct.
Exactly, resulting in a worsening depression that ultimately resulted in a catatonic state. And the danger of this is, certainly if you know these folks and you follow them through, you say, oh, this is not who they are. But to someone who is not used to treating people with autism, Down syndrome, intellectual disabilities, the mistake that often be made is, oh, this must be their baseline. Well, they're moderately intellectually
It's just
disabled.
chalked up to their
This is who they
developmental
are.
disability.
They have autism, and look, they don't
Yeah.
talk much. They have autism.
Yeah.
Is this? And if you don't have the developmental perspective, you look at them and say, no, this is not who they are. This is the end of a chronic depressive or psychotic disorder that went unnoticed, undiagnosed, and untreated, and yet there is very good treatments to both prevent this from happening and to treat it once it does happen. So
it's very critical that we obtain the baseline information and preceding events, a whole history from providers and from the family, so we can get a better understanding.
And particularly family, because as we say over and over again, family members know their child best.
Yes.
And so if a family member says this is not who they used to be,
yes,
we have to take it from that perspective.
Yes.
Yeah.
So what are the treatments, Dr. C?
Well, the treatment and diagnosis are similar, right? So we talk about doing something. I think the gold standard is what we call the lorazepam or Ativan challenge. So it's almost magical when it works. If you see someone, regardless of how they became catatonic, very often the medications, the benzodiazepines. So again, this is Xanax, Ativan, Valium, Klonopin. There's others, but those are the main ones. You give an individual a challenge of that, and by a challenge, you give them a dose, a couple milligrams of Ativan, usually by injection, just because a lot of times they're resistant to taking it by mouth, but if by mouth, that works just as well. And when someone is catatonic and it works, they almost wake up, well, as soon as there's a blood level, so in about 20, 30 minutes, they wake up, they start talking, they start eating, they start moving around. That only lasts as long as the medicine lasts in them, and they usually fall right back to it. That is kind of diagnostic of catatonia. When you give them a challenge of Ativan or lorazepam and they get better almost immediately, okay, this is what we're looking at. The real treatment is the treatment of the underlying condition as well. Mm-hmm. So if it's a major depressive episode, you're going to treat the depression, as we've talked about in the last episode. If it's a psychotic episode, you're going to treat the psychosis. But there is also some challenges with the treatment. So let's say that someone responds to a couple milligrams of Ativan and they kind of wake up and like, okay, here we are. They may wake up and be more agitated, which may be a struggle with the family. But what then we try and do is either give them a relatively large dose of that type of medication, Ativan or Klonopin, throughout the day. And when I say large dose, a lot of practitioners will be very hesitant to do this. Mm-hmm. A typical dose of Ativan would be 0.5 milligram, 1 milligram, 2 milligrams at the max. We may push people up to 16 to 30 milligrams a day.
Wow. Okay.
Of these medications. Very effective and actually quite safe, so long as there's not other underlying conditions they have to worry about. But a lot of the population that we see intermittently will refuse their meds. And these, Ativan has a withdrawal potential and a mm-hmm. life-threatening withdrawal potential. And certainly, if you're on a couple milligrams a day, it may not be that big of a deal. But if you're on 30 milligrams a day for 3 weeks and suddenly you stop, that can be life-threatening.
Right.
So it's a challenge.
Closely monitored.
Occasionally, we'll use medicines such as Clozaril, which we've talked about in other episodes, antipsychotic that can be very, very helpful. Lots of side effects, takes a little bit more time. And then if really the high-dose benzodiazepine, Ativan, Klonopin does not work, or there's a reason why we can't utilize that, the other gold standard treatment is ECT or electroconvulsive therapy, which we've talked about in the past and probably need to dedicate a whole episode to at some point. I guess the point I'm getting to is you won't be able to treat it if you can't diagnose it. You won't be able to diagnose it if you're not looking for it and realize that there's a high prevalence of it. But even if you've looked for it, diagnose it, and start treating it, in the ID, DD, ASD, and in this case, Down syndrome population, treatment can be difficult as well because of the difficulty of giving ECT to this population, of the difficulty of med compliance with high doses of benzodiazepines. So you really, maybe more than any condition we'll talk about maybe ever, need to have 100% buy-in from the family, 100% buy-in from the rest of the treatment team, and you have to determine what is the best environment to do this treatment. This may be one of the few times that you'll hear Janell and I say, we may need to do this in the hospital.
Right.
This is not something that we can do safely at home. So complex, very scary situation. a lot of mortality, a lot of morbidity associated with it, but also a very treatable situation. And so that's, I think, why it's such an important topic.
So we need to be on the lookout. We need to be aware. We need to be mindful of these symptoms.
Absolutely.
So if anyone is even remotely concerned about the possibility of catatonia, please reach out or inquire.
And
research.
it won't be surprising that your mental health provider may not be particularly aware of how high the rates can be. Hopefully this video can be something that families can even share with a provider. Again, we do this day in and day out, but it was only a couple years ago
that we were attuned to.
That we're really attuned, absolutely, and how prevalent it was. I mean, I was shocked to look at the actual numbers because we had at that point only had a couple cases.
Yes.
And so to me it seemed incredibly rare. And yet when you look at the research, it in fact is not. And I'm guessing that you and I missed it numerous times
previously
in our early years of Apex simply because we weren't looking for it.
Yeah. All right, folks, we're gonna end here, but until next time,
APEC out.
APEC out.